Hello and welcome everybody to our special webinar about hereditary amyloidosis sponsored by the Amyloidosis Speakers Bureau. I'm Elaine Abernathy, your moderator today, and also an HATTR patient. If you're familiar with amyloidosis, you're probably aware that it is likely widely underdiagnosed and that many in the medical community know little, if anything, about it, despite the fact that in the last 10 years, there's been an explosion of information. It still hasn't reached everybody. We hope to help change the current situation by offering webinars and presentations where patient speakers and amyloidosis medical experts discuss the disease. We're fortunate today to have two special guests for this webinar who will share their unique perspectives of the disease. Our hope is that by hearing about the clinical aspects of the disease from Dr. Rodney H. Falk and about life with the disease from an HATTR patient, Mr. Sean Riley, you'll gain some understanding and insights into this disease, and you'll be encouraged to work with your patient to question and investigate further when you run into pieces of the medical puzzle that don't seem to fit. That is one of the tricky things about amyloidosis. It can mimic other more common, typical diseases and conditions. But when you look holistically, it is its own separate thing. In our experience working with many amyloidosis patient speakers, it's clear that the physician-patient relationship is critical. It's imperative that the physician be open to the information the patient shares, even if it seems unusual and maybe counterintuitive. I'd like to welcome Dr. Rodney H. Falk, who is the director of the Cardiac Amyloidosis Program and the Cardiovascular Medicine Specialist at Brigham and Women's Hospital in Boston. He's also an associate professor of medicine at Harvard Medical School. Dr. Falk received his medical degree from the University of Birmingham Medical School in the United Kingdom. He then completed 3 residencies: internal medicine program at Brooks General Hospital, an internal medicine program at City Hospital, and a cardiology fellowship at Harvard School of Public Health. Dr. Falk is board certified in internal medicine and cardiovascular disease. He is also the author of over 100 peer-reviewed publications. Dr. Falk's research focuses on understanding cardiac amyloidosis and treatments for this rare disease. His research has been supported by the National Institutes of Health. We are incredibly fortunate to have him with us today. We're also fortunate to have Sean Riley. Sean is a retired nuclear reactor operator and professor of nuclear engineering technology and a hereditary ATTR patient who lives in New Hampshire. He began experiencing disease symptoms approximately 8 years ago, beginning with numbness in his left leg and bilateral carpal tunnel syndrome. Over the next several years, he lost approximately 80 pounds of weight and began experiencing episodes of low blood pressure and lightheadedness. After moving to Abu Dhabi in 2018 and experiencing multiple fainting episodes, a cardiologist advised him to return to the United States for testing and treatment. Sean's diagnosis of hereditary amyloidosis was confirmed at Brigham and Women's Hospital in February 2019, and his treatment commenced shortly thereafter. At this time, and very incredibly, the progression of his disease appears to be significantly slowed, if not stopped. Sean's anxious to help spread the word about amyloidosis in the medical community so future patients can be diagnosed, and treated at a much earlier stage of disease progression. We're incredibly fortunate to also have Sean with us today, who will share his experiences. And together with Dr. Falk, they'll talk a little bit about how their relationship as patient and physician really was instrumental in the diagnosis and journey to treatment for Sean. So without further ado, I'm going to turn this over to Dr. Falk and Sean Riley. Thank you very much.
Very nice introduction, kind introduction. And Sean and I go back, as you heard, to 2019, and we see quite a bit of one another.
Yeah.
Sean has been fantastic in being an enormous educational resource, and I'm just absolutely delighted that you and I I've learned from you, and I hope we've helped you, and you've learned a little bit from us as well.
Oh, absolutely.
So what I wanted to do here, and Sean and I have talked about this before, is initially I was asked to give an overview of familial amyloid polyneuropathy, a little slideshow. And obviously that's useful, but I don't know that that's the most valuable thing when we have such a valuable resource as a patient here, in such a good patient. And that's for two reasons. First of all, you can learn about a disease, but as a medical student or as a physician, you're never necessarily going to diagnose it, because taking the book knowledge to the clinic knowledge is quite different. The second thing is that although familial amyloidosis in particular, and to a lesser extent, other types of amyloidosis in general, are still considered rare disease, familial amyloidosis may well be rare, but others are somewhat more common. But amyloidosis is a paradigm for thinking outside the box and diagnosing uncommon diseases. We all, in our practice as physicians, see a lot of common diseases. And in my opinion, the thing that distinguishes a good physician, maybe an expert physician, from an average physician is the ability to say something isn't quite right here. And almost always, the diagnosis of amyloidosis arises when somebody says something doesn't fit. I've got to think of another diagnosis. I've got to think outside the box. And so what I hope is in a moment to start a dialogue with Sean and have, as though we were meeting for the first time, and have him take us through his journey. And I'll interject at various points with my thoughts and see how perhaps a diagnosis like this could have been made earlier. Certainly nowadays, even just a couple of years later, could have been made earlier. And also where aspects of it should raise a red flag to say something isn't quite right. So with your permission, Sean, if we can take a step back in time and have you, as it were, sitting with me in our very first meeting back in 2019, telling me your story, some of which I had gleaned from the episodes, from the records, but it was not a straightforward path. Isn't that correct? Well, just take us right from the beginning.
My symptoms started occurring probably about 6 years prior to that. At first, I noticed in my left leg, down near my ankle, I started getting some numbness. And at the time, I had mentioned it to my primary care physician, and we talked about it a little bit. And I had previous vascular surgery down in that area before that. So we kind of, I guess, wrote it off, if you will, as maybe some.
What kind of vascular surgery? You're talking about veins or arteries?
They stripped the vein the full length of my leg.
And how long before was that?
A couple of years, I guess, approximately prior to my starting to feel the numbness down there.
Yeah. So let me just, that connection is a little bit wrong there. That something 2 years before and presumably no numbness, and then numbness comes along 2 years later. Why a vein stripping should cause numbness 2 years later, it doesn't make a lot of sense. But A lot of people have little odd things in their feet, in this particular case, 1 foot. So we're not going to point any fingers here that it was just a little puzzling and nothing was developing at that point. So something going on in the foot now with something that went on in the foot 2 years earlier, a connection that doesn't make sense. And we all have that tendency to say, oh, you had something done before, maybe that's the cause of it. But then you have to think, well, wait a minute, why would it occur 2 years later? So there should have been a question mark there, but I don't think I would have been anywhere near a diagnosis at that time, other than to say, let's just keep an eye on it. Go ahead.
All right. So then kind of, I guess, concurrently or shortly thereafter, I started getting numbness in both of my hands, my thumb and index and middle finger. And I went to a local hand surgeon up here in New Hampshire, and she diagnosed that I had carpal tunnel in both hands. So I went and I had bilateral carpal tunnel surgery, and we didn't, at the time, we didn't really think anything of it. We just said, well, he, for one reason or another, developed carpal tunnel in both hands.
So numbness in the hands can be carpal tunnel syndrome. Here it was appropriately diagnosed. But again, what you have is a disconnect. We're beginning to see a picture like the elephant and the blind man. You have one person thinking about the foot and one person thinking about the hands. And in the past, a vein surgeon. Nobody's trying to see, this is a little odd. What is the picture that's going on here that's giving us something in the foot that sounds like a nerve problem and bilateral carpal tunnel syndrome? By that time, was your other foot involved at all, or was it still in the one?
I guess shortly thereafter, I did start noticing things in my right foot as well. But over time, it certainly has it spread and traveled up the legs.
And you're not diabetic?
I am not diabetic.
Yeah, because diabetes, of course, is the commonest cause of neuropathy. But neuropathy in a young person is unusual. And the questions that would come to mind of the clinician, and bear in mind, I'm not a neurologist, so probably for every question I ask, there's 10 more I should have asked. I maybe got the diagnosis, but I would want to know, we've already just established no diabetes. I would want to know, this is a little bit unusual. We seem to have a neuropathy and carpal tunnel syndrome. And is there any family history of anybody who's got nerve problems in your family, any kind of nervous disease?
My father passed away back in 1989, and my mother passed away in 2006. Both of them were forms of cancer. So there were in neither of them were there any, I guess, classic symptoms of this disease. Mm-hmm. I can tell you my father had cardiac problems and had bypass surgery. And he also, along the way, he had a stroke too. I'm one of 6 siblings, and 2 are deceased. Their cause of death appears to be unrelated to this disease. 2 of my other siblings that are still living both got genetic. And once they found out I had this, they both got genetic tested, and neither of them has the mutation.
So where are we now in the calendar? We're talking about what year approximately?
Oh, okay. So with my symptoms, going back to the, we're now headed towards, I guess 3 to 4 years. We're moving up to about 3 to 4 years prior to you seeing me.
So about 2015.
Yeah.
2016.
So at that time, I started getting what I thought, not being a professional, were cardiac problems. And I had a few episodes about a year apart from each other where I was getting symptoms that I thought were maybe chest pains or whatnot. And in both instances, I was taken to the hospital by ambulance. And I can tell you that during those episodes, it was actually what I experienced was almost fainting. I didn't quite faint, but it was almost fainting. And like I said, I thought it was a strictly like a classic cardiac problem. In both instances, I I was brought to the hospital. They did tests on me, EKGs, whatever the tests that you would do to check to see if someone had had a heart attack or not, and everything came back normal. So it was kind of confusing to me as to well, I've always been an athletic, healthy person. Why is this suddenly happening to me?
So that's again a lesson that's not, we can generalize here from amyloidosis to all sorts of other diseases. And that is when you have a history like this, that you felt that you were going to faint. And it's a long time ago, so you may not remember exactly what was happening. But do you have any recollection of what triggered those at the time?
No, in one instance, I was actually just sitting at home at my table doing work on the computer. And when I got up and stood up and started walking, that's when that feeling came over me.
Mm-hmm.
And again, at the time, I thought it was some type of a cardiac thing that was going on. But as I know now, it was hypotension. I guess an episode of hypotension. The second time that it happened to me was I was at work, and I was actually on the floor, standing on the floor teaching a class at the time. When I became dizzy, felt like I was going to faint, and in both instances, concurrently with the fainting, was kind of I guess an uneasiness in my chest that maybe that was just anxiety. I don't know, but those was in both instances. I felt like I was going to faint.
Yeah. So I don't know what they did at the hospital, but it's really important when you have somebody who gives you a sensation that they're going to faint, to try and figure out simple things as well as complex things. I don't know if you had an ultrasound of the heart at that time. You had an EKG at that time where the electrocardiogram was normal or abnormal. But there are very simple things that you can do that you may be able to pick something up, such as this. And they're often not done. One is very simply, you have the patient lying down and you check his or her blood pressure. You have them sitting up, you do the same thing. You have them standing up, you do the same thing again. And the normal response to that is that the blood pressure remains the same or even goes up slightly when you stand, because you have a normal response of the blood vessels constricting. But here you have a case of a gentleman who is telling you, look, if they take a good history, I've had this funny numbness in my feet. I've had something going on in my hands, and now I'm getting dizzy when I stand up. And although you may not have mentioned when I stand up, the history should be able to pull that out. And I don't know whether they did, and I'm sure it's lost in the midst of time, whether they checked your blood pressure lying and standing, because initially the drop can be intermittent. But the likelihood is, there's a decent likelihood that there may well have been a drop in blood pressure. And that should give the idea that there's something going on with blood pressure control. So now you have something suggesting a peripheral neuropathy in the past, a compressive damage to the nerve. And by the way, usually nowadays, the surgeons don't take any sample of that tissue for histology, but if they did, they almost certainly would have found amyloid in there if it had been stained properly. And now something that's suggestive of postural hypotension, which goes along with this whole neuropathic picture, but now with an autonomic picture, no diabetes. Diabetes will do all of those things. So you're looking at strange, unusual symptoms. And my bet is, again, if we went back and looked at those records, that they probably did an ultrasound of the heart, probably mentioned something about some wall thickening and ignored it. Because that, unfortunately, we see time and time again. But we don't know that at the time. And unfortunately, you were sent out with nothing wrong because they were focusing on the heart. The heart is part of the cardiovascular system. And they weren't concentrating on the vascular component, which is if we don't have enough tone in the circulation to maintain the blood pressure, as happens in autonomic neuropathy, which is a feature of familial amyloid, then you start getting dizzy when you stand up. And then the autonomic nervous system also affects the gastrointestinal tract. So one can have constipation, diarrhea, weight loss. sexual dysfunction, a whole host of things that can concomitantly or following or even before these aspects. But a simple test, such as checking the blood pressure standing up, which costs nothing, probably wasn't done. And I would guess that calculate, and could have been done in the emergency room, calculating the cost of that hospital admission was a lot more than the cost of lying, sitting, and standing blood pressure, and no diagnosis was made. And then what happened? The story continued.
Okay, so yeah, around because a lot of this stuff kind of overlap each other, but around that time, I started having bouts of acid reflux, and I was treated for acid reflux for a few years, and the medicines that they gave me didn't really help it all that much. And concurrently with that going on, I lost over probably a year and a half to 2 year period. I lost almost 70 pounds. I was a little bit overweight.
70 or 17?
70.
70.
Yes. So I went from just under 260 pounds, or I got down to, I was below 200 pounds. And my primary care physician was baffled by that. And again, they had me speak to a nutritionist. They even suggested, well, maybe possibly my lack of appetite could have been from anxiety or depression, because I can tell you that I was really quite upset as time went on, because these symptoms to me, I knew my own body, and I knew something was wrong. So it was very, very frustrating, and I kind of had I guess a rough time with it. So once again, my primary care physician had me speak to a nutritionist, and they did some other things, but really, it really came to, they couldn't attribute it to anything specific. But I knew in my mind, losing that amount of weight is certainly not normal.
Did you see a gastroenterologist? Did you have an endoscopy?
I had seen a gastroenterologist. The funny thing is I actually, back in 2006, had spinal fusion surgery, and due to the surgery, I ended up with a paralyzed vocal cord. So I had vocal cord surgery at Mass Eye and Ear in Boston, and then so my acid reflux symptoms started a short period of time after that. So I do recall that the gastroenterologist thought, well, maybe where you've got vocal cord problems and it's associated with your windpipe and your esophagus, then maybe perhaps the two are tied together. But that was kind of a loose connection that was made, but that was about as far as it went.
And no endoscopy. They didn't put a tube down.
I did, yes. I did have an endoscopy, yes. And it came back normal.
Yeah. Did they do any biopsies at that time, do you know?
No biopsy.
Yeah.
No.
So let me just take a quick aside here. Almost certainly, well, what we're talking about here is, now that the bowel is involved, that the gastroesophageal sphincter between the esophagus and the stomach is dysfunctional. Acid reflux is very common in general, and so, but weight loss such as that is not. So I would want to ask a few more questions. I don't know what the answers to these are, but if you can think back to those days when you were eating, did you find that you could eat as normal, a regular meal, or were you filling up more easily, or anything of that nature? Any diarrhea, constipation?
Yeah, it as far as being able to eat, it kind of fluctuated. Sometimes I could eat a large meal, no problem. Other times, I would, it's just like a feeling of fullness would come on early. As far as diarrhea and constipation, no, not at that time, but as time progressed, and certainly by the time that I was seeing you, I was getting bouts of that.
And what happened to these dizzy spells? Have they disappeared after those two, or were they still there?
No,
These fainting spells.
no, they were still there. And in fact, when I was, we opened the seminar here with, in my biography, we mentioned that I was living overseas. Well, that was actually what triggered, I was living over in Abu Dhabi in the United Arab Emirates. And fortunately for me, the Cleveland Clinic has a center over there. So when I was living over there, I did get, it didn't feel like I was going to faint. I fainted on, there were two occasions that were just like about 3 weeks apart from each other where I did faint. And I was brought to a local hospital. And when I say local hospital, I was living in a village out in the desert. So it was a pretty crude hospital. But on the second occurrence, the doctor there, he did tell me, he said, I'm not sure why this is happening, but you need to go into Abu Dhabi and go to the Cleveland Clinic. So 2 episodes where I did in fact faint were what triggered me or started steering me on the right path with this thing, if you will.
Yeah. So one of the problems of an endoscopy is that probably what you were experiencing along with that, sometimes you felt the feeling of fullness, and that's you can just think, oh, feeling of fullness, maybe there's something there that is making the stomach feel full, and go in and find nothing. The other thought that one should have is maybe the stomach just isn't emptying. Now, if you're having an endoscopy, as you know, probably for 12 hours beforehand, an upper endoscopy, you're not eating or doing anything. And if the stuff should be out of the stomach in an hour or so, and it takes 5 hours, well, now it's 12 hours, so they're not going to see anything, even though the gastric emptying is taking a lot longer. So the gastroenterologist is thinking of the pathology of the stomach, whereas the pathology is probably the pathology of the innervation of the bowel, which is dysfunctional because it's a neuropathy. So this is an autonomic neuropathy. If he or she had done biopsies, there would have been amyloid there in the stomach, almost certainly, or in the bowel, duodenum. One of the problems is that even if that is done, the average pathologist, the average hospital is not good at looking for amyloid. You have to have special stains to show that it's amyloid. A keen eye will pick up that there is something there that needs special stains. But we have seen, unfortunately, on many occasions when we look at pathology specimens that are read as negative, they're absolutely loaded with amyloid. And it's been completely overlooked because the person is not really looking for other stuff that's going on. And that was very unfortunate because now the picture is really becoming clear. There's an autonomic dysfunction causing weight loss. There's what was happening to your neuropathy by the time that you were really losing weight like that? What was happening to you?
The dizziness and whatnot was pretty frequent, like daily. I would have to battle it, and it got to the point where I couldn't climb stairs. I felt like if I climbed stairs, I would pass out while I was climbing up the stairs.
And so the autonomic neuropathy, so that strongly suggests that what was happening in the gastrointestinal tract was autonomic. What about the numbness that you described right at the beginning?
Yeah, so the numbness has and it has traveled. I'm glad to say now that its progression has stopped because of the treatment that I'm getting. But the numbness over time, when I say over time, obviously we're talking about a period of years. It did become bilateral in both feet and ankles, and traveled up to. I can feel numbness in my skin, and the nerve tests that they've done, the neurologist has done. There's numbness to one degree or another, all the way up both of my legs, up to my hips. I've actually got some surface numbness on my abdomen, and it feels like kind of into the abdomen muscles, if you will. And then again in both hands and pretty much up towards my elbows.
And was that present in Abu Dhabi when you were having all this gastrointestinal workup, or did it not reach that degree?
Shortly before moving over, the numbness was accelerating up my legs, and oddly enough, one of the things that I really remember happening was I decided that I needed to. I had taken a break from from exercising and decided that I needed to get in shape. So I attempted to try to jog on a treadmill, if you will. And as soon as I tried to get from a walk to a jog, it almost felt like both my legs were going to give out from under me. And I'm guessing that's probably from muscle wasting from the neuropathy. But yeah, like I said, the symptoms, the progression of the symptoms seemed to accelerate, and everything really came to a head during that. I'm going to call it spring of 2018 until I saw you in February of 2019. Yeah. The numbness in my legs, traveling all the way up to my thighs, that got more pronounced. Like I said, it kind of wound up or accelerated. So that got more pronounced in the last 3 or 4 years.
So we're really, we're in the midst now of, again, the blind man and the elephant. You have clear symptoms of autonomic neuropathy. It doesn't sound like anyone had even diagnosed postural hypotension, which was so apparent from the symptoms you're dealing with. You have a negative GI workup with a sense of fullness goes along with the other aspects of autonomic neuropathy. The testing for that had not been looked at. Going on the treadmill and feeling the legs giving way, you're absolutely right. Could be that the muscle's getting weaker, but it can also, when you exercise and you have autonomic neuropathy, some people have no drop in blood pressure going from lying to standing, but exercise brings it out because you vasodilate. And here you are in Abu Dhabi in a hot climate that is the best of people will drop their blood pressure somewhat, and you have an autonomic neuropathy, you're really going to be in a lot of trouble. And yet, no one had picked this up. So we're talking maybe 4 or 5 years ago, 3 or 4 years ago, perhaps. I will tell you that 10 or 15 years ago, a medical student and I, when there were these programs that you could put in symptoms, you could buy them for your computer, making medical diagnoses. We went through the case reports in the New England Journal of Medicine. We put in 2 or 3 symptoms from each one. And then we just used PubMed. And we had a very high hit rate of getting the right diagnosis. Now we're 15, 20 years on. We have in our pocket a diagnostic tool, namely your cell phone. And I haven't done this, but if whoever's listening, open up your cell phone, go to Google and put in postural hypotension and numbness, and it'll probably come up with peripheral neuropathy and autonomic neuropathy, and maybe come up with a diagnosis. And you can do the same with a variety of symptoms, and may give you 2 or 3 diagnoses, but you only have to focus on those 2 or 3. And if you put in bilateral carpal tunnel syndrome and postural hypotension, you'll probably get amyloid as a hit early on. We can all do that. And we can do that not just with amyloidosis, but with all sorts of rare diseases. We just don't. What we do is test upon test upon test. And if you're not focusing on the right thing in the test, you're going to get nowhere. We've got a computer in our pockets that we should be able to get that to now, but PubMed would have done it back then. So then you go to the Cleveland Clinic, which has a branch out in Abu Dhabi, and they began to latch onto it pretty rapidly. Right?
Yes, they did. At first, and you can speak to this because I've mentioned it to you before, and you seem surprised that they went down this route. But at first, they thought I had a condition called sarcoidosis, which I don't know much about. I know that the cardiologist over there, he did eventually, he did that, as you mentioned, the blood pressure test for the hypotension, where you test someone lying down, sitting up, and standing, and got that data. And then they did an ultrasound of my heart, and he noticed that there was thickening in the wall of my left side of my heart. So he amashed heads with one of his colleagues back from the Cleveland Clinic in Cleveland, where he had originally come from. And the cardiologist there, and I don't recall, his name escapes me, but he suggested to them that to Abu Dhabi that they consider the possibility of amyloidosis. And that's where they got your name and gave it to me, and they knew that I had lived in Boston, and they said, hey, you need to go back to Boston because if this is amyloidosis, they'll be able to figure it out in a hurry and treat you. So it moved on from there, and then ultimately I saw you.
The sarcoidosis story was actually, I remember what happened. And every so often I'll get a referral for sarcoidosis, which is a totally different disease. But people think because it ends in osis that it must be something to do with amyloid.
Yeah.
Of course it isn't. It's a totally different disease. The echo doesn't look anything like the echocardiogram, the ultrasound of the heart that picked up the thick walls. And there was an MRI. There was a cardiac MRI done in Abu Dhabi. And the features of cardiac amyloidosis on a cardiac MRI, now we're getting sophisticated, but the features of cardiac amyloidosis noted on an MRI are very, very different from sarcoidosis and very pathognomonic. Basically, there's not much else that looks like it if you do the test properly. And I actually think that whoever read it in their head got sarcoidosis and amyloidosis mixed up, because I remember that report which says features are highly suggestive of sarcoidosis, where in fact the features were absolutely typical of amyloidosis. At that point, the physicians who were looking after you latched on to the sarcoidosis aspect because a non-invasive imaging test had shown that, whereas in fact the clinical features were nothing like sarcoidosis. So it shows you this is a terrific, unfortunate example of when you are faced with a difficult diagnostic dilemma, and you have data, whether it's your own data initially or data coming from the outside, either it's coming from the outside, it was in the same institution, you review the original data and say, is this absolutely correct? Or if it doesn't fit, you have to ask the question, I shouldn't put aside the clinical features because it doesn't fit with the echo, which shows thick walls, which sarcoid doesn't have. And in fact, it was probably either a typo or a mental block on the person that delayed you for several months.
Yeah.
And this is not uncommon in medicine. An example that I will tell you that in light chain amyloidosis is that people don't recognize that the free light chains are abnormal in AL amyloid in almost everybody, the involved one, and they're also abnormal in multiple myeloma. But if you, in multiple myeloma, if you look for a protein in the blood, serum protein electrophoresis, 80%, 90% of the time, that's abnormal. Or it's only abnormal 40 or 50% of the time in amyloid because total protein that's being produced is much lower. And a lot of people stop at what they call the SPEP. They do an SPEP, UPEP, serum protein, and urine protein electrophoresis. It's negative, and they say it can't be amyloidosis because it's negative. It's less likely to be myeloma. It still could be myeloma. But amyloidosis is negative in 50% of the cases. And I've seen patients missed for up to a year because someone hasn't gone that next step and failed to understand that's the wrong test, even though it's in the same family. Here it was so we have a concept in medicine of pre-test likelihood and post-test likelihood. If the pre-test likelihood is not of sarcoidosis and it comes out showing sarcoidosis, you have to ask yourself, what's wrong there? Either the test is wrong, or maybe my pre-test likelihood is wrong, or maybe there is something just wrong in the report, as there was here. And unfortunately, that delayed you a little bit. But now it was becoming totally apparent. Autonomic neuropathy, peripheral neuropathy, carpal tunnel syndrome, gastrointestinal involvement, wasting of the muscles in the leg, weight loss. Was there anything else going on? I seem to remember you had some bruising at the time.
Oh, absolutely. And that still occurs from time to time. I actually, funny that the night that you and I were together at that function in Boston, it happened to me the next day. So it's actually probably, I don't know, 3 or 4 times a year, maybe, I will get a bruise right here on my eyelid. Right? It happens at the same place all the time. And it will last for a few days and then go away.
So the bruising is very, very interesting. Periorbital bruising. And when it's bruised, the rest of the eye is not swollen, right?
No.
And
In fact, I don't even notice it. Usually someone has to point it out to me because I can't feel it. There's no pain or anything involved.
Yeah. I'm just going to give you a couple of slides and show you how clinically it's really important to consider to do a physical examination. So you have these 2 fellows here on a desert island. One of them is complaining to the other, he's short of breath, maybe his legs are a little bit swollen, and he's eating a high sodium sandwich. So the other one happens to be a doctor. Says to him, have you experienced anything recently? He says, before that, he says, well, shortness of breath, so let me examine you. So I can change the slide. There we go. They asked him to look at his neck, and he says, take a deep breath in. Slow, deep breath in. Watch that neck vein. See those veins going up? Breathe out. And one more time, breathe in. And breathe out. Breathe out. So what you see here is something called Kussmaul's sign, which is described in basically only 2 conditions. And that is constrictive pericarditis, where the pericardium won't allow the heart to fill, and amyloidosis, not amyloidosis, take that back, restrictive cardiomyopathy, of which amyloidosis is the commonest, in which the heart is so stiff that it won't fill. Normally, if the neck veins are elevated, as they shouldn't be, but if the pressure in the heart is high, when you breathe in, the intrathoracic pressure goes down, so these go down. This is a Kussmaul sign where it goes up. And then you say to him, anything else? And he says, yeah, I've had this bruising around my eyes. Will anybody hit you? No. So now you don't get that in constrictive pericarditis. You get that in amyloidosis. So you've made the diagnosis. Now, this time when I show the slide, I say 2 things when I'm giving a talk. Not only have you made a diagnosis of amyloidosis, you know what type of amyloidosis this is. And this is almost exclusively seen in light chain amyloidosis. Now, we know that we're talking here about familial amyloid. And the other thing I say is there's one genetic mutation out of the 100 that I've seen in light chain in familial amyloidosis that also does that. And that's the so-called ALA60 Irish mutation. I've never seen it in any other mutation. And Sean, you are?
Yeah.
You have that mutation.
Yeah.
So you've got to look, and then you've got to look, and that's quite rare, but you're probably the 7th or 8th patient with this mutation that I've seen with a bruise. I've never seen it with any mutation. That should also have been a clue. Unfortunately, probably an average of 2 or 3 eye doctors, patients have often seen with this in AL amyloid. No one seems to pick it up. Similarly, with a large tongue, which is not seen in familial amyloid, AL amyloid. People go to ENT docs. It seems to be always missed. In fact, the worst diagnosis I've ever heard made for the reason this woman had a giant tongue was that she was menopausal. And can you imagine that? All the women in the world get menopausal, they don't develop giant tongues. She had florid AL amyloid. But we'll get back to the familial amyloid. Unfortunately, people, if they don't understand sometimes just what it is, they try and come up with a diagnosis that sometimes is ludicrous. So you came to Boston. We were lucky because really the diagnosis had been made. By the time you came, the diagnosis was clear. I didn't have to be a brilliant diagnostician at this point. I could just look back and say, oh, why did they not pick that up and so on? But hindsight is always easy. And we did the genetic testing and confirmed that this was the so-called Irish mutation, the ALA60 mutation, originally described by the recently deceased, much missed Dr. Merrill Benson. And just at that time, the FDA had released the silencer drugs, inotersen and Patisserine, and we got you on the Patisserine infusion. Tell us a little bit about that.
I started the treatment in, I think it was early May. And I've now actually I just had one the other day. I think it was my 34th treatment. You get it every 3 weeks, so that was my 34th treatment. And I can tell you that this medicine, the Patisserine, in my case, it absolutely. I show no signs, I don't think, of any disease progression. So it has, at the very least, halted the progression of the disease. So it started in May of 2019. So we're talking about 2.5 years now that I've been on this treatment.
So these are astonishing drugs. The silencers silence the production of transthyretin by the liver. It does this by targeting very specifically the molecular production of TTR. And you can measure the TTR levels. And you've got two different kinds of drugs in amyloidosis. And we skipped one step that we'll go back to in a second. That's the definitive diagnosis other than the genetic diagnosis. So the silencers, inotersen and Patisserine, lower very significantly by 80 or 90%. I think the normal range is 20 to 40 milligrams per deciliter. And we probably got you down to 4 or 5 milligrams per deciliter. If you don't have TTR, it's the breakdown products of the mutant TTR that cause the amyloid, so you're no longer producing any amyloid. The other feature that one should know, that we described this many, many, many years ago in AL amyloid, that, and it's probably true in TTR amyloid as well, that right before the amyloid fibrils are made, the what's so-called oligomers, which are the breakdown products of the TTR that get stuck to one another, they are themselves neurotoxic. So one of the reasons these drugs work very well is you no longer have these neurotoxic drugs that are directly affecting, toxic to nerves. So you have amyloid infiltration and toxicity. So things seem to sometimes improve or certainly stabilize, and you're no longer producing any more amyloid and pushing it down, nor the toxins. So those are the two ways that these work. And it seems to be a very well tolerated medication, a bit of a nuisance to get an infusion every 3 weeks. We just briefly go back and say, how was the diagnosis finally made? Because you are giving a drug here that costs huge amount of money, $400,000 to $500,000 a year by the time you include the infusions, and sometimes even higher. People have capped over $1 million worth of costs, incurred over $1 million worth of costs here. Insurance companies will pay for it, but there are other people who are struggling with this. You need a diagnosis. So obviously, you can't give it to someone who doesn't have the genetic form. In wild type TTR, which is a commoner form, we have a cardiomyopathy. Neuropathy is very rare, whereas in the familial, it's very common in most mutations. But you either need a biopsy showing amyloid, or nowadays, because Sean's heart on echocardiogram showed considerable thickening of the walls. Normal left ventricle is about 11 millimeters. Yours are probably 17 or 18 millimeters. If you calculate the left ventricular mass, it's probably almost double for the weight of the left ventricle. And if you use cardiac MRI, you can calculate how much of that thick ventricle is due to muscle, which in diseases like hypertrophic cardiomyopathy or severe hypertension, it's the muscle that's thick. Here, the muscle is not increased, but the surrounding, what we refer to as the extracellular space or extracellular volume, is expanded because that's all the amyloid, and that's markedly increased on the MRI. But those are indirect measures, what you're dealing with. We need a diagnosis, and a decade ago, that would have meant an endomyocardial biopsy, cardiac biopsy, where you take a piece of the heart and you look at it under the microscope and you appropriately stain it, either Congo red or sulfated alcium blue is what our pathologists prefer. And if there is the slightest doubt that you might be dealing with AL amyloid, and maybe the periorbital bruising here would have been enough to raise the doubt, you have to look at the molecular structure of the amyloid, which we could do with mass spectrometry. And we actually have at least one patient who has light chain amyloid, producing just a very slight increase in his light chains, but significant cardiac involvement, who also has an unrelated mutation, which is an amyloidogenic mutation, which is not causing his disease. When we biopsied him, we looked very specifically, there was no TTR, it's all A. So that's where you need to do a biopsy. But nowadays we get away without a biopsy in around 90% of cases, because we can use with technetium pyrophosphate, or in Europe, technetium DPD. It's a very similar isotope that's taken up vigorously by the heart, and a strong uptake in the absence of light chains, diagnosis of TTR, genetic mutation positive, it's the mutation, mutant form. And that's, I think that's what we did in you. I don't know, I don't remember whether biopsy, we didn't biopsy. But that it would be there if we biopsy. Your weight and your muscle mass, what's happened there just now?
At the start of treatment, I was, I don't know, 180 pounds-ish. And I'm actually back up over 220 now, and in fact, probably need to lose a little bit of weight. The muscle mass, I can tell you, in fact, I saw the neurologist recently. We've noticed that the muscle mass, the loss of muscle mass seems to be more pronounced in my left leg. And they actually did an MRI of my brain to see if there was any chance that in the past I had any type of a transient event or a mild stroke, because he was saying, well, I'm kind of surprised it's not, I guess, equilateral or whatever the correct term would be. But yes, I do still have muscle mass loss in my legs. Like I said, a little more in my left leg. However, my upper body, I've actually been able to do some light strength training and have slowly over time built some muscle mass back in my arms and throughout my torso.
Terrific. Yeah, I can vouch for that. Totally different from when we first met, and the lightheadedness.
From time to time, you do have me on the drug mitadrine that I will take. For a while there, we haven't taken it regularly, but now we've kind of gone to as needed with a lighter dose. And yeah, the lightheadedness, the drug helps. Plus, I've become my own expert in identifying what can trigger the hypotension and whatnot. So I'm able to compensate and do what I need to do to deal with it. But I have not had, I have not fainted since the time of my diagnosis. So that the fainting is all, hopefully that's in the distant past.
That's fantastic.
Yeah. I am so appreciative to the people that have attended this. Obviously, I have the disease, so this is a personal thing for me. But I've decided, as Dr. Falk has pointed out, there's a way to treat this disease now, but the trick is to get people diagnosed sooner than certainly in the case of myself when I was diagnosed. So any chance that I can have to kind of contribute to this and get the word out, and if it helps someone down the line, this is such a great opportunity, and I appreciate the attendance of everybody.
Thank you for participating. And I also, I just want to say that this disease taught me a lot over the 40 years that I've been involved with it. And it's taught me a lot about general medicine. There used to be a saying in the 19th century, when the common disease that was rampant was syphilis, which affected all sorts of organs, that if you knew syphilis, you knew all of medicine. And really, if you know amyloidosis, you have to know all of that. You have to know kidney stuff, you have to know neurology, you have to know a variety of things. The most important thing to know is, as I said right at the beginning, you have to listen to the patient, because the patient is telling you an awful lot. And you have to know your own limitations. I think a good doctor is a person who says, I don't know what this is, but it's not what the common diseases that I know, and I know who to send them to. And then the next person also has to think outside the box. You don't have to be a brilliant diagnostician for everything, but you should not shrug patient symptoms off unless you're 100% certain. And they should never shrug them off, but you should never say, make up a diagnosis. And in amyloidosis, that's done only too often. And finally, I would say that nowadays we have very easy access to genetic testing for this disease. It's one tick of a box. And to be honest, there's no excuse for any neurologist dealing with peripheral neuropathy not to tick that box. They tick 30 other boxes off for rare diseases. The answer then will be yay or nay for familial amyloidosis.
Thank you very much. A few questions here. All of us amyloidosis patients know that we have to be our own advocates in a lot of situations having to do with our disease. Sean was very fortunate to be able to early-ish on with his diagnosis, connect with you, Dr. Falk. But what about these patients who really don't know where to go and don't have physicians who are expert? What do we tell them?
What you tell them is only if they've already got the diagnosis, otherwise they wouldn't be coming to you. And that's the biggest problem, is once they got the diagnosis, I think it's extraordinarily important to be an advocate. The majority of patients we think who are diagnosed with AL have AL, or TTR have TTR, but some people don't. And you should go to a specialist center at least once or twice to get the correct diagnosis made. We also have an open door policy. If somebody thinks they have amyloidosis, patient or the doctor, even if we're almost certain looking at the records that they don't, we're happy to see those patients because we want to make the diagnosis, even if it's not amyloidosis. We recently took a vascular tumor out of a patient's heart who had been sent to us with cardiac amyloidosis in the pericardium because it was a misstained specimen, and they happened to have an unrelated monoclonal gammopathy and were already on chemotherapy. They ended up coming off chemotherapy, getting appropriate cardiac surgery, and so forth. We want to look at things with a fresh eye and tell them to contact any amyloid center in the area. We'll certainly be happy to see anybody, to speak to anybody if we don't see them. We want to help people. That's the most important thing. We have an open door policy, and we also put our patients centrally. And almost all my colleagues in the field do the same. That's not something that just the Brigham does. We like to think we do it most, but everybody else does it. And it's a fantastic community of physicians.
Yeah, when I was first diagnosed, the hardest thing for me, and that was 11 years ago, the hardest thing for me was access to information and finding out who the experts were, where to go. It's a little bit different now. No, I'll say it's a lot different now, actually. But still, there are pockets of medical communities that really are not that informed. So I appreciate your encouraging people to get to the experts. And Sean, did you know anything about the disease before you were diagnosed?
Never heard of it. Again, I thought, I mentioned earlier that I thought maybe I was having like, if you will, classic cardiac problems or whatnot, but no, I had never heard of the disease.
And do you get all of your information through Dr. Falk and his colleagues, or what other sources do you turn to for information?
Dr. Falk has supplied me with some written information on the disease. I'm there at the hospital every 3 weeks. So as far as information on my current status and condition and whatnot, it's ongoing and frequent. So I'm always up to speed with where I stand. I can tell you that I am a bit of a science-based geek, if you will. You read in my biography that I used to operate a nuclear reactor and taught. So I do have a science mind. So I'm not going to lie. I tend to go on the internet and do some of my self-research.
Yeah.
As you should, but with caution, with great caution.
Yeah. With great caution, right?
Especially for the newly diagnosed, the internet can be scary, but yeah. For Dr. Falk, and of course you do a really good job of this because you teach, but how do you encourage physicians to develop the skills to suspect when it's not obvious, to go that extra mile in developing their diagnosis, to look to curiosity and
Well, I think, you're absolutely right. I think it's curiosity. Probably the hardest specialty to be in is primary care, because the primary care doctor sees coughs and colds and colds and coughs all day, and then somebody comes through the door and something is different and it's serious. They've got an esophageal cancer because they can't swallow because of that, or their shortness of breath is not their asthma they've had all this time. They've now developed cardiac disease. And I don't know how. I think that an enthusiasm for medicine, a love of people, and the idea that when that person comes through the door, they're the most important person in the room and not the physician. You've got to have that. And if you don't have that, it's kind of difficult to give to people. But a lot of physicians do have it. And I just hope that they maintain it from their enthusiastic medical school days to their 40 plus years in medicine as I have passed now. So,
Oh, you've definitely maintained your enthusiasm. I can
thank
vouch.
you.
Yeah.
Thank you.
And I had one other, it's sort of a comment that came from our audience, and that was that a lot of patients, and I know from talking to a lot of our patient speakers that this is absolutely true, that they get dismissed as, oh, your symptoms were because of age, or, everybody has this as they get older. And so, it's a really tough situation then for the patient who really is looking for the physician to give them direction.
You have to have a little pushback there. Probably one of the wisest people I knew was my maternal grandmother, who, when she went to a doctor complaining of pain in her leg, he told her at the age of 80, it's just old age. And she looked at him and she said, "Doctor, that's nonsense. I've had the other leg just as long and that one doesn't hurt." We mustn't allow ourselves to do that. Old age itself, more diseases occur, but every symptom of old age is due to something.
Mhm.
And as the nation ages, diseases occur that can be treated. There's no wild type TTR has an average age of mid 70s, which means that patients are in the late 70s, early 80s, up to 90, and we can treat them. And there are many people I've got in their 80s who are still working, and active people who are short of breath because they've got wild type TTR. We shouldn't shrug that off. It's very tempting to do that, but older people have multiple diseases, and we just have to think of that. And it's insulting to tell a patient it's just old age.
I've also had a couple of questions that I'm not sure that we're going to have time to really get into this, or if it's something we really ought to be doing in the time we have left. But people become very confused about the treatments that are available now. We know that in the last 3 years, we have had 3 medications come to market. And there seems to be, like I said, a fair amount of confusion about what people should be on. I know most of us leave that to our physician. We talk about it, of course, but it's a tough one. It's a tough one.
It is, and it isn't. And for TTR, for AL amyloid, there are a host of drugs that are out there, and more every year. AL amyloid, you really only have 2 types. You have, as we talked about, the silencers, of which there are 2, inotersen and patisserine. Patisserine is Onpattro, and Tegsedi is inotersen. And then you have the stabilizers, which stabilize the molecule, prevent it breaking down, and hence prevent amyloid. And that's tafamidis, Vyndamax, Vyndaqel. Tafamidis is only approved for cardiomyopathy, not for neuropathy in the United States. The other 2 are only approved for neuropathy associated with a positive gene. So you've already got a dichotomy there. So if you've got a lot of neuropathy, you go with a silencer if your gene is positive. Otherwise, the cardiomyopathy, you can have genetic or non-genetic. we have the data on tafamidis. Probably they work as well. There are clinical trials, and that's the final thing, is that clinical trials, don't be frightened of clinical trials if you're a patient. Clinical trials are always surveyed very carefully by Human Studies Committee. They're always watched very carefully by ethics committees. You have to do them properly. And the physicians themselves are exquisitely aware of anything that might be going on that's negative, but often there's a positive outcome. So the only way to get these drugs to market is through clinical trials, and sometimes they're placebo-controlled. But if you have a good physician, he or she will tell you, will give you the information, but not tell you to go. Give you the information, let you think about it, answer your questions. And if you're interested, you should always feel free to ask questions all the way along, whether it's a trial, whether it's a treatment, whatever is going.
A big thank you to Dr. Falk and Sean. I mean, this was wonderful. I know I got a lot out of it, and I'm sure everybody else in the audience did too. It's a unique opportunity to have the two of you.
It's a privilege to, I don't know who the audience is made up of, but it's a privilege to be teaching or informing or reinforcing stuff that they already know. Thank you. And thank you, Sean, for all you've done for patients. And for keeping us on our toes as well.
We really look forward to you joining us again in the future. I mean, we want to continue to do this. We want to continue to spread the word. And, you know, the more people who know about amyloidosis in all its various forms and all of its variants also, and HATTR, the better. The quicker we can get to diagnosis and then treatment, and maybe share in Sean's wonderful outcomes so far. That's terrific. Thank you again. We do appreciate your time. Until next time, goodbye.